This Is Us podcast. We are so happy and excited that we have reached 9 episodes so far.
9 already.
We are very happy to have all of you who have been joining us week after week, sharing with our guests as we interact with our guests on various topics. And tonight is just the same. We have a very interesting lineup tonight, and we're excited to have our guest. The guest that we have tonight is another esteemed guest. All our guests are esteemed guests, and we're so happy to have them join us each time we meet on a Thursday at 8:30. So welcome and thank you for joining us on This Is Us, where we share our story, your story, our journey, your journey. I am Latoya Berry Jones.
And I am Teddy Jones.
And this is us.
Welcome. A couple of weeks ago, when we had our friend Camille share with us about the shock and drama and pain of becoming a widow at an early age, I made a comment about having the experience of living and thinking that there are some things at that time that widowhood was only something that affected old people. I only knew of old widows. Now this evening, as I was reflecting on this evening's show, the thought came back to me that there was a time when the only persons I knew with certain medical complications were older women. I have an aunt who had surgery to remove fibroids, and I mean, she was maybe at least 50 at that time. And then I knew a couple other persons in that same age bracket. And then not long after that, I started hearing of girls as young as 8 and 9 and 10 with cysts and fibroids and all of that. And I was like, wait, hold up a second. What's going on here? What's up with that? When did this move from something that affected older women only to affecting seemingly women, females on a whole, right? It is what it is. And then interestingly, a couple of days ago, I was trying to find back the article on Twitter. I came across this article where they were saying that this study is now making a link between, ladies, listen carefully, and no disrespect meant here at all, is just what the study was saying, that ladies who have been using chemicals to process their hair over an extended period of time, that the study was finding a link between the chemicals involved in the processing of hair and reproductive health issues. Now, of course, maybe that study needs to be further peer reviewed and all of that. And we'll ask our esteemed guest, Doc, to weigh in on that perhaps a little later on. But we have something very, very, very important this evening. If you're a female, make sure you lock in and call up your sister and say to her, hey, tune in, log on, something critical for the females and also for the men.
For sure.
We need our men to be in tune to this episode, because what affects our ladies affects us. Title of this episode, Her Body, Her Pains. And we're going to look at the implications of what happens in her body, what happens with the pains that a female experiences, and how that has an impact on a relationship and on the men that are in the lives of these women. So who do we have with us this evening, babe?
So tonight we have a very special lady with us. We have Dr. Clovet Hessing with us tonight. Thanks for joining us, sis. And
welcome,
I
Doc.
say sis
What's
because
up, Doc?
we're also sisters I won't tell them if it's by blood or by what. We're sisters. So
Right,
tonight,
right.
Dr. Clovet Hessing is a consultant obstetrician. I hope I get that pronunciation correct.
I
Gynecologist.
won't even try.
Having completed her medical studies at the University of the West Indies, and Zanele is helping me, Mona, she went on to serve at the Cornwall Regional Hospital. She subsequently completed her specialization in obstetrics and gynecology at the University Hospital of the West Indies. Dr. Hessing is also a fellow of the American College of Obstetricians and Gynecologists. Not only is she a women's health advocate, but Dr. Hessing is also a mental health advocate through her motivational talks on her various online platforms. She is a devout Christian, family-oriented, fun, vivacious, and always ready for a road trip. Welcome, 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 Doc. Welcome, sis.
Thank you so very much.
It's great to
Yes,
have
it
you
is
here.
indeed my delight.
Welcome. Good to have you.
Yes.
It's great to have you here with us tonight as we talk about a very important topic that, you know, some people are comfortable talking about, some people are not so sure what it is. And I hear it's a very technical it's disease. Should I use that word? For I'm not a doctor, so I'm using words loosely. I'm sorry, but I'm sure you correct me.
Yeah, I'm not even sure if it's a disease.
Right. So, Doc,
we'll
shed some light for us tonight. And before we go into our discussion, tell us, who is Clovet Hessing?
Well, thank you so very much for having me again. It's indeed my delight to be able to join you on your podcast. I think you did a very good introduction. I kind of summed it up there. But as a physician and as a women's health physician, I specialize in women's health care, maternity care, after maternity care, as well as gynecologic conditions for women, right? That's what I do as an individual. As you said, I'm a Christian, and that shapes a very important part of my identity, which is separate and apart from what I do, but also comes to bear on whatever I do in life. And of course, all the other fun things that I love to do, including singing and road trips, right? All right, so endometriosis, very, very, very important, very complex disease condition that affects women, right? Endometriosis has not necessarily become more common, but the awareness of the condition has definitely been risen, and you guys, the Joneses, have really been a very integral part of that. So kudos to you and your team for raising the awareness as it surrounds and as it relates to endometriosis.
All right. So, Doc, just pause a little bit, because I want to make sure I'm hearing you clearly. Are you saying then that the complication, I think I'll probably be safe in saying complication, that the complication was actually around, but perhaps misdiagnosed or even undiagnosed, or maybe confused with other things all along, but now, much more awareness of it.
Right. So the endometriosis definitely could have been misdiagnosed. And so let me just give a broad understanding of, because I know you have aired endometriosis already on your podcast, but for those who are just joining, endometriosis is really a chronic inflammatory condition that usually affects the menstrual cycle and fertility in women, right? So what usually happens is that usually on a monthly cycle, the inner lining of the womb is shed to give the menstrual period, right? Let me just bring up my little model here. Let me see if I can just do a little demonstration.
All right.
Right. So inside here would be your lining. So this is the womb, and it's a cut section here so that we can see inside. Right. On either side, we have the fallopian tubes. This one is not well. This is not a normal tube, right? I will explain. So yeah, this is
it looks enlarged.
Yes, this one is enlarged, right? And we'll get to that. And then you have the ovaries here on either side. This one is cut open so we can see inside. This one is not, right? So this is the vagina right here, right? So generally now, each month, an egg is released from the ovary. It's basically swooped up by the tube. It travels in, right? During the time when it's preparing, the egg is being prepared to release, the lining is also being prepared to receive the fertilized egg. So the lining of the womb gets thicker, gets more vascular, full of blood vessels and so on, preparing for a fertilized egg, preparing to receive a pregnancy. So when the egg comes down and the egg is not fertilized, then the lining will shed.
Right.
Right? And that will be the period. All right? That would be the menstrual period. And that's on a monthly basis. In endometriosis, what happens is that there is the lining still there inside the womb, but there are areas where the lining gets on the outside of the womb. So it may be resting on the tube. It may be resting on the outside here, that could be represented by these black dots here. Could be resting on the outside of the womb, could be resting on the outside of the ovary, could be resting on the outside of the tube, could be resting on the outside of the back of the vagina. Could be resting on the bowel, which is at the back of the womb, could be resting on the bladder.
Whoa.
Could be resting on the bladder, which is right in front of the womb here, could be resting on the ureters, which are the tubes leading from the kidney to the bladder, right? And not only can it rest on these structures, it can also do what we call infiltrate, which is kind of grow into or become large and cause what we call inflammation, chronic inflammation, which we call, okay, let's see. If you have a cut, if you get a cut, then you know it heals with a scar tissue, which will be like what we call scab in Jamaica. Right? And that scab, basically, you know, the skin is going to be tethered or drawn up, wrinkled.
Yes.
Right? As the cut, especially if it's a large wound, as it heals, the scab will get harder and harder and bigger. Right? So,
gotcha.
So too with, that is what we can see on the outside as acute, when the cut is just starting to heal, acute inflammation. And then when that scab, as we call it in Jamaica, that large chronic inflammatory healing process, or fibrosis is what it is called medically, but it's what we call scab in Jamaica, that heals over, that is chronic inflammation. As it occurs on the outside, it's a similar process that's happening on the inside as regards to these deposits of endometrial lining that is outside the womb, because it is abnormally placed and the body is trying to remove it.
Right.
And as the body is trying to remove it, it is an inflammatory process. The body is trying to heal itself. And as it's trying to heal itself, it will start to create the wrinkling and the scab, which is scar tissue. And the wrinkling can cause you to have bands being formed between different tissues, which is kind of trying to be represented here, if you can see clearly, these white bands. So these would be like once the wrinkling is taking place, if my hand was naturally there, it would get stuck to it.
Wow.
So what is happening? Yes, what is happening on the inside as it's trying to heal or get rid of these, the endometriotic deposits, these black dots, it's causing inflammatory tissue, which is what we call adhesions. And these adhesions is causing the ovary to stuck to the tube, or the tube to stuck to the ovary, or the tube and ovary to get stuck down to the bottom of the pelvis near the vagina. And once that happens, then this becomes dysfunctional.
Right.
So a number of things can happen. The tube can close off, which we commonly call blocked tubes. And that whole process can lead to infertility.
Yes, yes, yes.
Because the egg is no longer able to pass, the tube is not functional.
Right.
In addition to that, if the deposits are on the ovary and infiltrate into the ovary, once you have a period, these deposits become activated. So they are also hormonally sensitive. So they respond to estrogen as much as the inside lining responds to estrogen. Those that are on the outside also respond to estrogen. So once you start to bleed on the inside, you start to bleed on these areas where it is at also.
Oh.
And that is what causes the inflammation.
Right. So it's like you have
the whole cascade of events.
Yeah, right. So it's like you have the period happening on the inside as well as on the outside,
so to speak. Right? And so it offset this whole cascade of events where the body is trying to remove these things here, because you shouldn't be bleeding on the outside, or you shouldn't be having this leaking from these deposits, which is what is happening each month with the menstrual cycle, right? So once that is happening, then if it is on or within the ovary, remember it can be anywhere outside the uterus, within the pelvis, within the belly. Yeah. Within the pelvis, which is the lower belly, colloquially. That leakage or that blood or that fluid can collect in the ovary and result in what's called a chocolate cyst, which is an ovarian cyst that is filled with the blood leakage and called chocolate because of the dark color appearance.
Okay, but by now it's hardened, eh? or is it still liquid, like a pustule?
It can be liquid, it can get solid areas over time, but it's usually liquid.
Okay.
Right? And it can be drained at surgery. But the point that I was getting at that affects infertility is that once you have that cyst in there, it's going to suppress your ability to ovulate. Once you have a cyst there. So that's one, that's a cyst, that's the fallopian tube that's getting blocked or kinked or bent or stuck down, or the end could be blocked, like this one on this side here, it's blocked, and so this end is swollen. And fluid can collect in here, right? That's causing that tube to go bad. All right, so I kind of went into like a quick overview or summary, but also started to address some of the questions that could possibly be posed as it relates to endometriosis.
Right. Yeah. So is it triggered by the onset of the menses, or can it happen even prior to the menses? Because it sounds almost as if it is the menses that kind of precipitates it.
All right, so the underlying cause and etiology of endometriosis is still unknown. However, the main theory behind it is what we call retrograde menstruation, which is where instead of the menstrual flow coming down, some of the menstrual flow is going up and into the fallopian tube, right? And it's coming into the fallopian tube and seeping out through the tubes into the pelvis or into the lower belly, as we say colloquially, right? So rather than the blood flow as a menstrual cycle, the blood's supposed to flow in one direction and come down. Rather than coming down, we have a retrograde, which means backflow. So for some reason, there is some backflow, and maybe when the uterus is contracting to get rid of all the blood, you can have some cells being backflow through the tubes coming out into the pelvis and around the womb, around the uterus, around the tubes and around here, and get stuck there and begin the inflammatory process.
Wow, Doc, I've heard a lot, and I am seeing it. It is very visual, it's very literal, because you have explained it in such a way that it's very simple for someone, anybody, to really understand what you're talking about. And then I'm imagining myself as a woman, and you mentioned infertility, and even though I'm hearing what you're saying, Doc, is like each sentence that you say, it's like it's a whole new topic in and of itself, because you mentioned, you mentioned infertility, you mentioned menstruation, and so on. And these are terms that we hear a lot, and some people take it for granted that because I'm a woman, everything is going to happen naturally and easy, or it will come natural and in a particular sequence, and so things will just fall into place. And sometimes when we are not educated on these things, because a simple thing like period, a lot of young girls, they are not exposed to information and education about their menstrual cycle, and about how to prepare for it, how to care for themselves while having their periods, questions to ask, if there are different signs, and so on, that can cause a difficulty or complication later on. So it's as if it's something that should be spoken about
definitely
early as a young woman starts, or even before she starts her period, because there's so many things that can go awry with just the menstrual cycle.
And usually if you see a teenager that is having severe menstrual pains,
that's where I was going,
nausea, and nausea and vomiting, then you really want to get to check to see if she could be having early features of endometriosis, because what could be happening is some retrograde menstruation could be happening there that's causing that severe pain. Because once the cells seep through the tube and into the pelvis, into that area where they're not supposed to be, then the body's natural response is going to try to remove it, and in that trying to remove it is going to offset inflammation, and that is going to be very painful. So that's where the pain is associated.
And though, Doc, you touched on it, but let us, and for all the women out there who are listening, all the mothers and even the men too, the symptoms, Doc, because sometimes we can, and as Teddy was saying, the misdiagnosis or undiagnosis of endometriosis, is it easily identified just by symptoms only, or is it that you have to do a battery of tests to say, hey, yes, you are suffering from this thing called endometriosis? Is it as plain as that, based on just symptoms only?
It is not based on symptoms only, but it is a high index of suspicion, especially if you see a specialist like myself, like a gynecologist, right, who will be more familiar with the presentation of endometriosis, right? But we definitely mentioned severe menstrual disruptions, so severe menstrual pains. But then again, that's exactly what it is. It has to be a high index of suspicion. We have to take the whole clinical picture together, right? Because the persons can have menstrual cramps, dysmenorrhea, for several reasons. All right. And so that's going to be associated with difficulty conceiving, right? We know infertility is one of them, but we also know that infertility is not only a woman's problem, it's also a man's problem, right? So that's something that is usually investigated in a couple setting. So I usually see
Okay.
both partners together,
Mhm.
and we work up
Mhm.
each partner separately.
Yes,
But
yes.
the initial consultation involves both, definitely, and so that we can be on the same working page and have a work plan to move forward with in terms of investigating both partners, right? So we just wanted to
Yeah.
highlight that one,
Yes. And
right?
I know for sure that there are women out there listening and, who may be suffering from things like this, and they just don't have a name to it, but they're just and probably suffering in silence. And I'm glad you mentioned that you do a workup for both partners, for the male and also for the female. But Doc, you are showing us the diagram of what it looks like, but how do we
But
get
I
there?
just, before you go on,
Mhm.
Latoya, with
Yeah,
regard to the symptoms, I want to add,
yeah.
because I was deliberate when I mentioned the bladder and the rectum in terms of relation
What
to
was
the
it?
uterus. Hi, good evening, welcome. Could we ask you to thank you for joining. Could I ask you to mute your mic? Thank you very much. All right, so that's my my other guest, my cousin Vanessa. Thank you so much.
Okay. Hi, Vanessa.
Hi,
Along
Vanessa.
along with
We,
Rotaract Club, representing Rotaract Club of Ligonier Plain.
My
Oh,
apologies. I
welcome.
did not realize my mic was on.
all
Sorry
right,
about
that's all right. That's all right.
That's
Welcome,
all right.
welcome. Good to have you. Yeah,
All
man.
right.
Yeah, yes, Doc. Right.
So as I was saying, I was very deliberate because the bladder is right in front, and the rectum is right behind, and this is very important with regards to symptoms. So if there is endometriotic deposits on the base of the bladder or infiltrating into the bladder, it can have pain on urination, it can have bleeding, blood in the urine. With regards to the rectum, you can have pain on passing stool, or even blood in the stool, depending on how infiltrating the endometriotic deposits are, because it can really get parasitic, for want of a better word.
Yeah, because
Right?
I'm picturing that. I'm picturing like
Yes,
Venom,
some
the
of them
movie
can be
where it just
superficial, but some of them can go deep within, below the tissue layer, as it becomes more and more activated with each menstrual cycle, right? And not only that, if you have deposits within the pouch behind the uterus, just behind the uterus, then some patients, that's what we call deep infiltrating endometriosis, and this can affect sexual intercourse. So on the penetration, that sexual intercourse is going to be very painful for these couples with deep infiltrating endometriosis, with endometriosis that is causing the fallopian tubes and ovaries to be clubbed into the pelvis, that is affecting the rectum, that is within the pouch behind the uterus, just behind the vagina. Also, if it is within the septum, if it goes to infiltrate within that tissue that's separating the vaginal wall and the rectum, which is what we call the vaginal septum, then there's going to be very painful intercourse, and there's going to be pain on passing stool.
Wow.
Right, right.
I was going to touch on infertility, Doc, but I feel like I want to do that as a topic by itself for another time.
Yeah, we have
it is a whole topic.
Yeah,
It's a whole
yeah,
topic.
definitely.
But what I want to get at, Doc, is endometriosis something that can be seen from a ultrasound?
It depends on the stage.
Okay.
The
extent and it depends to which it has grown, I suppose, the tissue.
Right, because what happens is that when you have chronic inflammation, as I said, with the acute inflammation, you're going to just have like a little mild thing. With chronic inflammation, can actually have a whole scab, right? And so if what you're looking for on ultrasound will be like a ovarian cyst or a chocolate cyst, which is in endometriosis is called an endometrioma or a chocolate cyst, then that will be, you'll be able to see cysts. You may be able to see some larger deposits, right? But for early stage endometriosis, you may not be able to see it on ultrasound. You may have to do an MRI to see the deposits within, around the womb, or these little ones that may be stippling around. and thing like that.
Okay.
Right? As I mentioned, with regards to the diagnosis of endometriosis, it is a clinical suspicion, but the diagnosis is what we call a histopathological diagnosis.
Can you explain that? Okay.
Meaning to say,
Stay with us. Stay with us.
Peel off this part.
Yes.
If it is just on the surface, peel off this part, send it to the lab, look at the cells, look at the type of cells, and then say, yes, definitively, those cells are distorted because of endometriosis.
How do you get that?
That is by surgery, either by open, but laparoscopy is now the way to go. Minimally invasive surgery or laparoscopy.
Right.
And that means, what that means is a surgery where we use buttonholes on the abdomen, one at the navel, and probably 2 or 3 others. We put a camera inside at the navel and put instruments in that we can use to peel off. I wanted to upload a video so you could get an idea to see what that looks like. But I did ask Teddy to put up 2 photos so we could take a look and compare the normal looking pelvis versus the pelvis that is riddled with the endometrial adhesions.
Sure, let's get that up. Let's get that up.
Yeah.
And while I get that up, we'll just take a quick break, and we're gonna come right back with Dr. Clovet Hessing, taking us through the ropes, literally going through the ropes as it relates to her body, her pain, looking at complications in the female reproductive system. We'll be right back. All right, and we're back. All right, back with you, Doc. Take it away. The images are on screen.
I have no
Okay, could you give me the first? Could you give me
the other one? You want the other one? Okay. All right. There you go.
Awesome. All right. So this, we're looking at a relatively normal pelvis, and this is when we go in. This is what we see on laparoscopy. This is not my image.
Okay. So this is an actual image taken with one of the invasive cameras.
Right?
The laparoscopic camera.
Yes.
Good.
Right. So, all right, which is really a laparoscope. All right. So this bulge here, where you see the bladder, is literally the back of the bladder that you're looking at here.
Okay.
So just to give you an orientation.
This one.
We're up here.
Okay.
Where you see the word bladder.
Right.
That's literally the back of the bladder that you're looking at, right?
Okay.
Which is a posterior wall.
Yep.
All right. Which is directly in front of the uterus or the womb. So we're looking, basically, we're taking an aerial view, which is a view from above.
Oh, okay.
Right.
Right. And so on either side of the uterus, I'm not sure if my pointer is visible to you guys.
No, it's not.
No, we're not seeing.
No. Okay. So on either side, extending on either side would be the fallopian tubes.
Very
right. So looking from above. So that shine part.
Sorry, 1 second.
Are you going to share so I can?
Yeah, 1 second. There you go.
Okay. Right. So where it's labeled uterus, that's the top of the womb here. Extending on either side is the fallopian tube. And you go all the way out to the end. That's the opening there when you go all the way out to the end. Then the 2 white, pearl white structures just below.
Yeah.
Those are the ovaries.
Oh,
okay.
That's
Is
how
that like, that's the actual color? That's the actual color in real life?
Yes, that's the actual. This is actual.
Okay.
This is actual that you're looking at.
Mm-hmm.
Right? And so if you can imagine now, if you have the blood coming up, or the cells, endometrial cells coming through the tube to the opening there, then all of that is going to be dripping. Those cells are going to be dripping behind the womb here.
Right.
Right? And when it's dripping behind there, it's going to eventually lead to things getting stuck together, things getting stuck down, things getting hard. They're not going to be soft and supple and flexible anymore.
It's crazy.
Right? So below, because you're looking from above,
Mm-hmm.
so below you will have the cervix. So that's labeled cervix there.
Mm-hmm.
Below cervix, behind that, you will have the vaginal wall. You will have the vagina. So you're looking at it actually from behind and above.
Behind and above, yeah.
This is what you are seeing.
Trying to picture behind and above at the same time.
Yes, so this is what you're seeing. So when everything comes through here and is dripping out, it's going to be dripping behind here, dripping down behind the cervix. In the space there between, that's pouch of Douglas, is that space between the back of the vagina and the rectum.
Never heard of pouch of Douglas before.
Yeah, so when all of that drips down in there, it's going to, imagine that's getting harder and harder, tougher and tougher. So once, remember, cervix is right there, vaginal wall is right. Once you're having intercourse, that is going to be very difficult and very painful, because instead of things being flexible, it's going to be hard and rigid. Yeah?
Yeah.
And then also behind there, you have the rectum. So to pass stool is going to be difficult, right? And you have those ligaments there that are labeled. That's supposed to help as well with supporting the womb and the flexibility of the womb. In the whole dynamic is going to be shifted. All right, so when we can look at the other picture now, we can see how things are going to just get matted on, stuck together, and that sort of a thing. So right, so you can see how things just get distorted. This right over here looks like it is enlarged with a cyst, an endometriotic cyst, right?
They just get big.
Yeah.
So these.
Yeah. Yeah. Notice how they are kind of bungling into each other.
Right. They are not only bungling together, they are literally stuck together.
Okay.
And if you see there's like a band. So just beside the right ovary, I'm suspecting that this is the left ovary, and you see like a band between the uterus and this structure there.
Yes.
Those would be what would be represented like this on here, these white bands. So they can be anywhere. They can be between this and this, stuck this to this.
Yes.
To the side, can be stuck down into the base of the pelvis and that sort of thing. So when we go in for laparoscopic surgery, we use various instruments to separate it, to separate all these adhesion bands, to drain out the cyst or remove the cyst wall as best as possible, to get the structures back to being nice and supple, and to get structures back in their normal alignment as best as possible. And to strip away, if you look and see the red dot stippling the back of the uterus, that's how the endometriosis starts out. And a superficial type of just stippling way, and we can actually strip these off.
Right.
But eventually, if it stays there, it's going to start forming adhesions. It's going to start infiltrating. It can even get into the bowel and that sort of a thing, and cause a huge problems. Different persons have different stages for different reasons. There isn't any particular etiology that says, okay, this person will end up having stage 4 versus this person may not have.
Right.
This person might have deep infiltrating versus this person just have stage 1. When it is just mild like that, in terms of just the stippling on the superficial, just on the surface, we usually call that as stage 1, and that's early stage, right? Another huge thing about endometriosis is that it is what is known as a great masquerader, meaning the proportion of pain, the pain is not proportional to the stage or grade of the disease. So one individual can have just a stippling, early stage, and they can have a significant amount of pain.
Right.
More than the person who might have stage 2 or stage 3. So it is not proportional by any means.
Yes.
Right?
Doc, okay. When you're through with the diagram.
Yes, so pretty much that's what I wanted to highlight with this diagram. Is how messy it can get inside, but surgery can be done to in majority of cases. I mean, when you have deep infiltrating, you will have to have a multidisciplinary team, depending on what other organs are affected. So if it's bowel, we need a general surgeon. If it's a tube that's leading to the bladder, then we will need to get the urologist involved, because then we will need to have their input in the surgery, so on and so forth.
Right. It's really not that simple.
It can get complex.
I think really after this, I can get my medical degree, Doc. I feel like I'm in med school.
Yeah, but so Doc, quick question. PCOS, endo, fibroids, ovarian cysts, what's the difference? Is there a difference? Are they all just different flavors of ice cream? Or are they ice cream and orange and cake?
They are definitely separate entities altogether.
Yeah. Wow.
Separate, and I could do a whole podcast on PCOS alone.
Right.
Because it is a totally different pathology, cause, and etiologic basis from endometriosis. And fibroids is a total different thing too.
Wow. Because I mean, I used to think that they're kind of like all
related,
from the same family,
from the same quote unquote family. But yeah, you spoke about pain. On a scale, if there ever was a pain scale, where would the pain be if there was a pain scale? What is it comparable to? I know it varies from woman to woman, but generally speaking, is there a way to kind of conceptualize like what is this pain likened onto?
All right. So generally speaking, when we ask somebody to describe pain on a pain scale, we usually compare it to what they would consider their worst
because of
pain.
the threshold.
Oh, right. Makes sense.
Right. So each individual has a different quote unquote pain threshold, right? But that being said, so we usually say 10 is the worst pain you have ever experienced in your life. But then again, there may be persons who experience different scenarios and may not have yet experienced the worst pain that they could have hypothetically experienced. So I usually say, would you describe this as a labor pain?
Right. If the person
and the assumption then would be mine that the labor pain would be the severe, the most
example. So let me just come in right there, Doc.
That is why pain is subjective.
Yes,
right?
Because when I was pregnant with Zaken, and I was so nervous
into labor
with Zaken, I was so nervous, and I asked the doctor, I asked one of the doctors on the ward, like, just tell me what the pain is going to be like, please, before I go into labor. And she said to me, it's going to be the worst period pain you ever felt in your life. And I said, all right, that means I can manage, because my period pains, them hit me, but I can manage. I can stand up on my own 2 feet.
There you
But
go.
when that labor pain hit me with Zaken, I said, what a doctor lie? I almost died.
Probably
So
she never went into labor. So
exactly.
she wouldn't be able to tell you. To be
Exactly.
honest, the
So
pain is very
exactly.
subjective. That's the bottom line,
Right.
right?
Right.
So that's one. So that's labor pain. We could compare it to, or we could compare it to some person say the passage of a kidney stone.
And I don't know what that feels
I,
like.
I've heard that that is extremely painful.
We heard that that is extremely painful.
Yes, and I mean I've seen somebody writhing in pain from what was later diagnosed as a kidney stone, but either kidney or gallstone, one of them.
Right. So at its severest point, it may be at or even worse than those. That's crazy. How terrible endometriosis pain can be.
Thanks, Doc. So, Doc, take us through, explain to us, is surgery the cure, or what's the sequence? You have a patient that comes in, experiencing symptoms, you go in laparoscopically, we see something like the last picture, or it's getting to that point. What regimen do you put, each patient, depending on what stage or what's underlying issue, or if they are high risk, or all those things. That's one. Also, I want to get in, is Black women susceptible? That word? More susceptible to, yeah.
All right, so I'll answer the easier one. It's just a second question first.
Okay.
So no, usually the prevalence is not necessarily higher among Black women. There's no racial predilection for endometriosis, right? With regards to the management of endometriosis, it is multifaceted. As you can imagine, yes, we would need to do laparoscopy to get the definitive diagnosis, but again, the diagnosis is clinical. We can start managing the patient's pain. It's really symptomatic management, right?
Okay.
Laparoscopy is not the cure-all. Surgery is not the cure-all, because a lot of times you're going to have recurrence. Sad to say, it's going to come back.
Okay.
I mean, even if you go in there and you remove all that, you can see all the little stippling areas, you drain all the cysts, you remove all the cysts, you do all of that.
Even if you remove the womb totally?
Well, if you remove the womb totally, that will significantly cause an improvement. That will be significant improvement. But guess what? Remember that the retrograde menstruation would have already taken place.
Right.
The peritoneal lining of the pelvis would have already been affected.
Yeah.
So remember, it's not just the womb, around the womb, but also the pelvic side wall.
Yeah.
Some of the cells would have leaked onto
yes,
the other surfaces.
Yeah. Especially if it has been there for a while and has
So we would have done what is called peritoneal stripping, which we would have stripped off as much of the tissue that would have been affected, that's on the pelvic side wall within the pelvis, where it would have spilled onto. Right? But even if we strip it off and remove the womb, it can still come back. I mean, you will have a significant improvement because the source would have been removed. But then you would have already had the cascade of inflammation would have already started.
So, Doc, I think we have questions and comments that we're going to share with you in a moment.
A comment,
actually. Before you go on, I just wanted to mention, to stick in there now with regards to the management and the pain management. We would start with our general analgesic therapies, which would be like your NSAIDs. Your NSAIDs, which would be like your ibuprofen, your Voltaren, And then we'll move up to the higher power. So there is a pain stepwise management. Some patients who have severe and debilitating pain, we have to refer them to a pain specialist.
Wow.
So there are different specialists along that so as I say, it's multifaceted, it's complex, right? And so we'll start there. And then we will also institute hormonal therapy. And the basis of this is to stop the periods.
Okay.
Right? And so the theory is that if we stop the periods, then we would decrease some of the spilling. If the spilling is still taking place, we would have also decreased the influence of estrogen.
Yes.
Because remember that estrogen is influencing the shedding of the lining. And if estrogen is influencing the shedding of the lining, it's also activating the other areas.
Yeah.
And once the other areas are activated, then that is the inflammatory cascade that's taking place again.
Yes. We had so many more questions to ask and wanted to ask about even how a woman's partner, husband can really support. But I think this is a part 2, Doc. I mean, we cannot cover it so much. It is so much
multifaceted.
And it's so informative. And I'm going to allow our viewers to
put some questions in. Okay, awesome.
All right, so just a comment from one person viewing on YouTube to protect her identity, but I happen to know that she told me that she had 7 surgeries so far to address endo, right? And so she's just confirming, she says, it can be very painful to pass your stool and also your urine.
Right, as I had mentioned.
Right, as you mentioned.
Several surgeries.
Seven.
And that speaks to the recurrence, yeah?
Yeah,
so
exactly.
Comes back.
Right. And then your mother says, I like the explanation, Doc. All right, so she's tuned in. And we have some persons over there on Facebook as well, just encouraging you and commending you on the presentation. All right, so again, the time just blows away.
I did not realize the time
we've barely scratched the surface.
Barely.
So we're gonna work out with you when you can come back and do a follow-up with us.
Right, because we want to talk about the emotional and the psychological impact not only on the woman, but on the couple. On their relationship, and also the hormonal therapies that are available as alternatives to surgery.
Right. So closing comments for those women out there. All right. Anita says very informative and enlightening, a sad one for women. Absolutely, Anita. And it's very sad for women who are experiencing such. We totally agree. And we stand in full solidarity with the women who are suffering thus. So closing words,
remarks with regards to
encouragement. How would you encourage those women who are battling with this? As you said, what was the term you used? Not silent, but you said
the masquerade.
The masquerade, battling the masquerade. A word of encouragement to them.
I would, as the awareness of endometriosis has arisen and is on the rise, women should know that they are not alone. Women should know that there are a lot more. There's a lot more information. Women should know that there are support groups. They're actually endometrial support groups that you can get connected to. And I find that this is very, very helpful for women going through this struggle. You don't need to go through this alone. It can be very debilitating. It can be very emotionally exhausting.
Yes.
Just to say the least, financially, emotionally, and relationally taxing as well. And you would really benefit from being in a support group. all is not lost. Whilst surgery is not the cure-all, there are treatment modalities available that can improve your quality of life as you go through this journey.
All right, great.
Thank you.
Yeah, and I mean, again, we're going to come to, because that's another thing we maybe want to hear you weigh in on. Anything in terms of diet, just, scratch the surface.
Well, that's a whole, yes, that's a scratching the surface again. So with regards to diet, again, we know that the basis for the pain is inflammation and chronic inflammation. And so we want to assist the body as best as possible to decrease and to heal itself. And so we will talk about your anti-inflammatory foods and your natural antioxidants.
Okay.
Right.
All right. Great.
Right.
Great.
So your polyphenols and these your CoQ10s and all of these that will be your natural antioxidants to help the body to decrease the amount of inflammation that's there, so that it can assist in your pain relief. Yeah.
Okay, great. Thanks a lot. So we're definitely going to get some more on that as well. In a moment, get ready to share with us where persons can get in contact with you. So we'll have you end on that note. Another comment here. I know of a married couple that was having sexual issues because of endo. She has been delivered, so that's a plus. Well, great, happy to hear that. And we have to get some more into that. So friends, listen, the replay is going to be available on the YouTube channel. Make sure you subscribe to the channel and tap the notification bell so you don't miss any of the videos, any of the episodes. Make sure you're following us on Instagram and like the page on Facebook. On Instagram and Facebook, the handle is This Is Us Jones Clan, and follow us on YouTube. Doc, where can persons find you?
Right. So you may be able to contact me on my social media platforms at Clovet_Hessing. That's my Instagram handle, and Facebook at Clovet Hessing.
All right. And it's CLOVET, one T, HESSING. All right.
Correct.
Right.
Dr. Clovet Hessing, thank you
Looking
so
forward
very
to a part 2.
Yes.
Oh, yeah.
I'm definitely looking forward to it. I'm sure we're going to have lots more comments, questions. People want information. People really need information on these things. So we are very, very delighted to have had you with us tonight on This Is Us, where persons share their journey, their story, our stories.
All right. So
thank you so very much for having me.
Absolutely. The pleasure is ours. Stay safe, everyone. Keep the faith, keep strong, keep focused on the positives. And remember, we're all in this journey together. I'm Teddy Jones.
I'm Latoya Berry Jones.
And this is us.